Ma'am, we are live and ready.
So, hello everybody. I bring you greetings from Pune, Maharashtra, which currently has a lot of COVID tests, COVID cases. And I want to thank the South Zone UA Foxy organizing team for giving me this wonderful opportunity to sharing with you whatever little I know and have experienced in context with vaccines in pregnancy. Today, as we understand that pregnancy and prenatal care has become a very, very important window of opportunity where wonderful modifications to ensure a proper social outcome and healthy outcome in the society can be planned. And this is me, Dr. Girija Wagh from Pune, in clinical practice and academic practice for the past 29 to 30 years. So, what are we going to see through this small presentation? Introduction, rationale, what is to be given, what is not to be given, and the summary of vaccination of women during pregnancy. Now, we all know vaccines are very important, especially during pandemics. We've been recently in the middle of one in preventing a lot of serious outcomes related to preventable diseases. So, women should be vaccinated against preventable diseases in their environment prior to conception, also, is a very, very important thing to practice. And the risk of exposure during pregnancy can be high to the baby as well as the mother. And this also has to be used as a wonderful timeline. So, if you look at this particular chart, which is very easy to understand and can be a part of your clinical place where you can look at these vaccines, we have to understand that there are quite a whole lot of opportunities that we can have before pregnancy, during pregnancy, and after pregnancy if anybody has missed before pregnancy, because it is high time that we started adopting adult vaccination from starting it in young women and then encouraging it to the entire population. So, if you look at the vaccines such as hepatitis A, B, influenza, meningococcal, pneumococcal, Tdap, and TD, these are, and even varicella, can be the ones which can offer optimally before pregnancy itself. But if the woman has missed this boat, then there are some of these which can be given. Of course, the ones which are live vaccines, like the varicella, rubella, cannot be given during pregnancy. And the influenza vaccine, which we give during pregnancy, is not a live vaccine and which can be given safely. Now, today, world over, there is a lot of understanding of giving a tetanus, diphtheria, and acellular pertussis to pregnant women to prevent these diseases not only in the mother but also in the baby. Naturally, the question comes to our mind, what do we do about the COVID-19 vaccine? Because now it's been available to the general population, and therefore we have to be well versed with what's happening. Unfortunately, we still have not made up our mind about this because there are a lot of propositions and objections which are being taken. But for our information, we have to understand that the WHO states that they do not have any reason to believe that women should be deprived of taking these vaccinations, and pregnant women, especially the ones who are healthcare providers or who have comorbidities that add to the risk of having a possibility of a severe disease, may be vaccinated in consultation with their healthcare providers. So, with this information, we have to, because it's a pandemic like a situation, it is important that we follow the local guidelines and in accordance practice what is going to be given as far as COVID is concerned. So it's important before, along with planning pregnancy, that the woman is up to date with her vaccination. And there are several infections such as varicella, rubella, which can be prevented before the woman goes on to become pregnant. Now, before you decide to give her rubella or varicella, ensure that the woman is not pregnant already and then only deliver this vaccine to her. And it is found that many a times pregnancies are unplanned and therefore women never turn up for these vaccinations. So there are various windows of opportunity, like the woman coming with a miscarriage or coming with some pregnancy mishap or for urinary tract infection. These are the times where we can consider giving them rubella, hepatitis B, and varicella vaccinations ahead of time. And then we have to also tell them that it's better to defer a pregnancy for 3 months. And this is important because it has been shown that if a woman is vaccinated against rubella, there can be a significant reduction in the occurrence of congenital rubella syndrome, which is much high on the rise. And obstetricians, it doesn't come to us, but there are many a times such kind of babies presenting to a neonatal clinic. And therefore, world over, and we have our own prime minister talking about this rubella vaccination, it is important that it is awarded to women before embarking on getting pregnant. What we have to, however, remember is sometimes if the woman has been given rubella vaccine and she conceives immediately, that is not an indication for termination of pregnancy, please remember, because no untoward side effects have been observed in the babies through whole lot of studies done world over. So if you have given the rubella vaccine and if the woman conceives, please do not order her termination because nothing goes wrong with the baby and there are many studies to support this. Likewise, do not miss on the opportunity of giving hepatitis B and HPV vaccination before pregnancy. Now, during pregnancy, if you look at the universal tetanus toxoid administration, we have finding that tetanus toxoid is not completely eradicated, but definitely it is reduced significantly. Adequate enough. The first one being at 16 weeks of pregnancy, and the second one being somewhere around 23 to 26 weeks of pregnancy. And if at all the woman has already had a recent tetanus toxoid dose, only single booster during pregnancy can be important. However, giving tetanus is not a substitute for not having clean delivery practices, and that has to be remembered. Now, many a times there are concerns about safety of the vaccines, and it has been found that there is no evidence of harm to pregnant women or fetuses for administration of inactivated vaccines. Live vaccines that are considered safe in children and adults may be harmful to a developing fetus. Vaccines can augment an individual's immune status, and all but the live vaccines are generally considered safe for administration to pregnant women. And the safety and timing is very important because it's always better to delay it until the second trimester. There is no harm whatsoever, but it is to avoid any spurious associations if there are in the patient's mind, which can associate this vaccination event as a reason for miscarriages or birth deformities in the baby. Additionally, if the vaccination is given between 26 to 32 weeks of gestation, it is known to cause optimal antibody production and transfer to the fetus because healthy pregnant women are able to mount a similar immune response to vaccines as healthy non-pregnant women, and transplacental passage of antibodies depends on maternal concentration with significant amounts of IgG are transported but not IgM and IgA, and preferential transportation is found in IgG1, and this is determined by the gestational age. Now, the fetal IgG concentration is found to be much lower than the maternal concentration in the first half of pregnancy, and it is known to increase 50% of maternal levels at 28 to 32 weeks of gestation and equals maternal levels by 36 weeks of gestation and often exceeds the maternal levels at term. So, because the maternal IgG levels reach their peak about 4 weeks after immunization, the gestational age at maternal immunization is an important factor when passive neonatal immunity is the goal. For example, the pertussis vaccine that we are talking of. In these cases, the ideal timing of vaccination is in the early third trimester to achieve maximum maternal antibody levels and maximum antibody transfer after delivery. And certain infections such as HIV, malaria, are known to modulate the MTC transfer of the IgG antibodies and very high maternal IgG titers overall or to specific antigens also can inhibit antibody transfer due to competitive inhibition of active transport. However, it is extremely important to definitely advise women to practice proper immunization of the entire family and maintain good hygienic practices. Now, there are concerns. Are there going to be any problems if inadvertent vaccinations or vaccinations are given to pregnant women? Now, especially gestational rubella infection, if it happens during the first trimester, then there can be, associated problems like severe behavioral consequences, autism, or there can be sometimes issues such as maternal inflammation due to some other viral or bacterial infections, which can be linked to such kind of ASD disorders in the babies. So, being a mother is learning about strengths and you didn't know you had, and dealing with fears you didn't know existed, is what Linda Wooten would say. And therefore, we have to understand that we must preemptively encourage women to take vaccines correctly. We have had a huge lot of experience from the H1N1 pandemic of 2009, where we found that many pregnant women were seriously affected by flu infection. And then it was found that flu shot, when given to women, prevented these abnormalities in a much, much better way. And therefore, the government of India, the WHO, and many global organizations promote influenza vaccination during pregnancy because pregnancy alone is a risk factor for severe disease. Risk is even higher in presence of comorbidity, and there is increased risk of hospitalization, most commonly for acute cardiopulmonary illnesses, and therefore it has to be given to all pregnant women through entire trimester. Anytime you get an opportunity, please give the flu vaccine because complications are higher in pregnant women and vaccinations help in reducing these complications. So, if you look at the strategy of antenatal maternal immunization to prevent infection in infants, it would give passive protection to the baby, especially during the first 6 months, 74 to 80% reduction in the PICU hospitalization, reduce incidence in babies by about 50%, decrease adverse fetal outcomes, and definitely cost cutting to the pocket. Is maternal vaccination necessary for protecting the baby against pertussis? Is another question. And the answer is yes, it is. Because there is a huge case fatality rate associated with fatal pertussis infections, which are concentrated amongst women where infants who are too young to be protected through routine vaccinations. And maternal Tdap vaccination, which is now the standard of care in the US and the UK, is the most effective way to address this gap in the preventive care. Since 2010, CDC sees between 10,000 and 50,000 cases of pertussis each year. And in 2012, CDC saw the most cases in 60 years. And there were 48,277 reported cases. And therefore, there is definitely a resurgence of diphtheria and pertussis world over. And this pertussis can cause serious and sometimes life-threatening complications in infants and also in newborns. And most pertussis deaths are infants who are too young to be protected by childhood pertussis vaccine, which is the DTaP. So if there are no pertussis vaccines licensed or recommended for newborns at birth, and therefore the best way to prevent pertussis in a young infant is antenatal vaccination and cocooning, meaning vaccinating the entire family and administering the childhood DTaP series on schedule at 6 weeks. Now, in 2016, the Advisory Committee on Immunization Practices of the CDCP recommended an approach of cocooning to prevent neonatal pertussis, which means that entire family needs to be protected and the mother has to be offered the antenatal tetanus. And there are various such kind of pertussis vaccine options that are available. And there are various kinds of vaccinations, and there are sometimes fears that there may be serious reaction. But then it has been found that in 1981, a new type of acellular pertussis vaccine combined with DT toxoids vaccine was introduced, and thereafter there was no such adverse reaction. So one recent study found that only 37% of pregnant women had anti-pertussis antibodies, and after a dose of Tdap, this figure rose to 90%. And almost 95% of newborns were born with antibodies. So presumed protective levels were maintained in 66% babies at the age of 2 months, and it was said to be then attributable to effective maternal vaccination, and vaccinating pregnant women appears to be an effective, safe intervention for protecting babies. So pertussis antibodies reach a peak 2 weeks after vaccination and decline thereafter. And therefore, women vaccinated with Tdap early in pregnancy do not transfer adequate levels. And therefore, it is always better to give them this vaccine between 27 to 36 weeks of gestation, which will optimize antibody transfer, which mainly occurs between weeks 36 to 40 weeks of gestation and provides protection. Maternal vaccination was seen to protect babies against pertussis in the UK, where vaccine coverage among pregnant women was 64%. So, the effectiveness of anti-pertussis antibodies in bacterial pathogenesis neutralization, emphasizing the importance of placental transfer and breastfeeding in protecting infants against respiratory infections caused by Bordetella pertussis, was published in 2010, and it has mentioned that you must offer it. Now, what do we do in premature babies? Premature babies will receive very little placental transfer, and it is not known what effect the transplacentally acquired antibodies will have on the development of immunity in response to primary DTP series. So the WHO position statement speaks about vaccination of pregnant women is likely to be the most cost effective vaccination because can be achieved. So it's important that protection from 5 life-threatening diseases such as diphtheria, pertussis, tetanus, hepatitis B, influenza is offered to the mother to reduce this being transferred to her baby. And this is the FOXI guideline, which talks about that the regular pertussis is contraindicated in pregnancy, but Tdap is, even if it's that time it was not available, but it can be given. And if in the subsequent pregnancy, we can consider giving patients the Tdap, the regular pertussis vaccine, and the Tdap should be given to the patients. So let's talk about postnatal vaccination. The FOXI recommends that if any of the vaccinations have not been given to her, please make her up to date during the postnatal period. So this was about the influenza vaccination and the cocooning. And to summarize, we have to look at preconceptional rubella, hepatitis B, varicella, HPV, use opportunities to do that, antenatally tetanus toxoid, tetanus plus diphtheria. And if you don't have an access to Tdap that time, TD can be given instead of only plain tetanus. Give Tdap, that is tetanus plus diphtheria plus acellular pertussis at 24 to 28 weeks. Influenza can be given anytime during pregnancy, and hepatitis B also can be given any time during pregnancy. Postnatally, if the patient has already not taken tetanus, give her TD if she's not taken, or the pertussis she's not taken, influenza, hepatitis B vaccine. And even if there are mishaps, preterm deliveries, missed abortions, IUD, do not forget to give these vaccinations to these women. What is very important is that we all are well aware with the correct dosages and storage recommendations. And we should also remember that these are notifiable diseases, and the vaccine should be kept between 2 and 8 degrees centigrade on the middle shelves of the refrigerator and never to be frozen. And you have to remember that you, as a doctor, are going to be the one who is going to introduce vaccines to your patients, because it has been studied and found that the patients listen more often only to the doctor. You can always go to the FOXI website to look for the GCPR on vaccinations in women, which is there on the website for your referral and ready reckoner anytime when you feel like. So I end my talk by quoting Pandit Jawaharlal Nehru: ignorance is always afraid of change, and time has come to a change. And this is me, Dr. Girija Wagh. I can be contacted anytime for anything that you need at girijawagh@gmail.com, or you can visit my website, or you can call me on the phone number 9422 and I'll be happy to help you with any questions that you have to ask me. Thank you so much, and I hope you have a wonderful event. And I pray to God that sometime I'm able to personally visit you and meet you. Thank you so much. Thank you.
Thank you, ma'am. That was wonderful.
Thank you.
We really miss you in the live.
I know. If I can come, I'll run. Don't worry.
Yeah, that would be great, ma'am, if you can be there on time. I mean, on that day, at
Yeah.
least for your talk.
Yes.
Thank you very much, ma'am.
Thank you. Be safe, be serene, and bye bye.
Bye, ma'am.